Hi class, happy Thanksgiving. I'm glad we were able to offer this lecture online for you all. This lecture covers postpartum complications. Remember, the postpartum period begins immediately after birth and extends up to 6 weeks after. If you'd like to follow along in your textbook, it's between pages 2171 through 2190. The majority of this lecture will cover two topics: what can go wrong, postpartum complications, and also the intricacies of breastfeeding. We will briefly cover some psychosocial changes that occur in a mom who's delivered a baby. And we will have some old material from postpartum assessment from our last lecture together on slides, but I won't actually be covering that information because it will be a review for you all. Please note there will be some slides that have no audio, on which I will say there is no audio. Postpartum assessment. No audio. No audio. Breasts. Breast assessment is the first B on Bubble He, which you guys have already learned. But here we're going to talk about abnormal deviations from a normal breast exam. Mamas can have inverted or flat nipples on one or both breasts. And remember, breasts are very different from the other. They're not mirror twins. So a mom could have an erect nipple on one side and an inverted nipple on the other, and it takes a keen nurse or a keen lactation consultant to tell the difference between each. A great way to correct inverted or flat nipples but still allow mom to breastfeed is the use of a nipple shield, which is depicted on the bottom left-hand side of the screen. Many breastfeeding experts suggest the temporary use of a nipple shield for difficult or persistent latch-on problems. As you guys can see in the picture, it's made of a thin, soft silicone. And what mama does is she places a nipple shield over her nipple, and it has a hole at the tip that allows milk to flow to the baby. And these are utilized when mom has anatomical abnormalities, as seen here in these pictures, flat or inverted nipples. And if it's difficult for the baby to draw the mother's nipple in, the baby will pull away or cry or even just fall asleep. But the nipple shield provides sensation deep in the mouth that stimulates the baby to keep sucking. We also heavily utilize the nipple shield in sick babies, small for gestational age babies, or growth restricted babies, or babies that are premature, because the nipple shield may make feeding easier for a small or weak baby. The nipple shield suctions to the nipple, so it holds the nipple in an extended position, and the baby can pause, especially if the baby's weak, without losing or letting the nipple go in the mouth. So the milk will still pool up in the tip of the shield, and it will provide an immediate reward when the baby resumes suckling. This is a review of how to perform a fundal check. Remember, the fundus is the top part of the uterus. When assessing the fundus, first make sure mom doesn't have to urinate. It could be very uncomfortable if she does. Assume her in a supine position. You'll want to assess 3 things and document 3 things about the fundus. Remember this. First, to assess the height and its relationship to the umbilicus. You'll assess the location, or whether or not it's midline in the abdomen, and then you'll assess the consistency, whether it's hard or soft. Remember to place your dominant hand at the top of the uterus and the other at the bottom to support that lower uterine segment. And you usually document it as it's related to the umbilicus. For example, if it's at the level of the umbilicus, it will be U. If it's 2 finger breadths above, it will be U plus 2, so on and so forth. The uterus should descend daily at approximately 1 to 2 centimeters per day. Because this is a postpartum complication, we're going to focus on the question on the right-hand side of the screen. What deviations would I expect in a cesarean section? And all of you guys should answer. I would expect the woman to have a surgical return of bowel function, just like any other surgical patient. It could take up to 72 hours to have bowel sounds return, and you would want to slowly increase her on her diet until the return of sounds. First, she would be on clear liquids, then regular liquids, then regular foods, or according to your hospital protocol. Again, remember, it's critical to assess the document. Apologies. It is critical to assess and document the first urine void. There's a lot of reasons for that. We have lots of things that are working against mom postpartum to make her not urinate, which is, definitely a cause for concern. First and foremost, her endogenous production of oxytocin or our synthetic administration of pitocin acts as an antidiuretic hormone. So already we're giving her a hormone, or she's making a hormone endogenously that will prevent her from urinating. Second, mom may have had an epidural or spinal block, and she may not have full nerve return of her bladder. She may not be able to sense that her bladder's full and needs to be emptied. Okay, also, last but not least, lots of trauma going on down there postpartum. She just delivered a baby. Her urethra may be very swollen, which can cause a delay. And all three of these things stack up together and cause urinary retention. It's very common in postpartum women, and most units have a standing order that if she has not voided within 4 hours, to go ahead and perform an in and out cath. Remember the importance of bladder distension. The bladder and the uterus compete with each other and the abdomen for space. So if the bladder's large, it will take over and won't allow the uterus to contract, causing a boggy uterus and a potential postpartum hemorrhage, which we'll talk about more at the end of the lecture. A full bladder will increase the tendency of the uterus to relax by displacing the uterus and interfering with contractility. No audio. No audio. This is a nice review slide for you all. We've covered this already. Remember that lochia transitions from rubra to serosa to alba. These timeframes are just very slightly different than the timeframes listed in your book. Both are relatively correct to each other. Lochia is a Greek word that means related to childbirth, and it's the uterus ridding itself of debris after birth. What's important to know is that when the lochia stops, the cervix is closed, and at that point and that point only can the woman return to sexual interaction. Otherwise, if she's shedding lochia and she has intercourse, it will increase her risk for an infection. Important teaching here when a mama goes home is to tell her that what her lochia will change into. It will start to be dark, heavy as it is now. It will progress to pink or even brown, and then eventually for several weeks it will be white. It's important to teach her that if for any reason it regresses, so if her lochia is white and it regresses back to brown or even red, then she needs to contact her doctor. Also, lochia should not smell foul. It will smell musty, normal, but it shouldn't smell foul, and if it does, again, she needs to contact her provider because it could mean an infection. A nice review again for you. Not only do you measure the type of lochia, but you measure the amount after birth. No audio. No audio. No audio. Homan sign. Can't tell you how important it is to assess for a DVT in a postpartum patient because they are so at risk for a clot in these women. To elicit a Homan sign, you bend the knee and you dorsiflex the foot, meaning you take the toes and point them towards the nose. And if the mom complains of pain in the calf when you dorsiflex the foot, that is considered a positive Homan sign, and it is a big concern for a DVT. You don't want to elicit a Homan sign in a patient that already has clearly a DVT, meaning her calf is already reddened, it's already swollen. You don't need to try to do a home and sign in those types of patients because your senses are already heightened and you could dislodge a clot that's already there. But let's talk about risk factors. This is important. Why are postpartum patients more at risk for clots than other patients? First and foremost, think about all the progesterone mama has circulating in her body. Okay, what does progesterone do? It relaxes. And not only does it relax, but it dilates. And it dilates the deep, deep veins deep in her legs and other parts of her body. And the deeper those veins are, the more likely the blood can pool in them. And when blood pools, it clots. Also, mamas postpartum have limited mobility, especially if they're post-cesarean. So that's another increased risk factor for DVT. And they do have elevated clotting factors after they deliver because their body is actively trying to clot. So what do? We walk them. Best prophylaxis. Mamas who have had a vaginal birth need to walk the day of delivering, and mamas who have had cesareans need to walk the day after. This not only will walking help with DVTs, but it will help increase urinary output. It will also help decrease constipation naturally, and it will even lessen after pain. No audio. No audio. Let's talk about psychological assessment in a postpartum woman. For you guys that have already been in the clinical setting and have witnessed a birth, you guys can feel the emotional change in the room after mama has delivered. And the very last letter in the acrostic of bubble he is E, emotional assessment of mama and baby. It's important to make sure mom and baby and partner and baby are bonding before we discharge, because if we have concerns, if baby cries and mom doesn't pick baby up, we really should not send that baby home. We should put in a social work consult. I want you guys to know that the baby can start to hear in mom's belly in the second and third trimester. So when babies are born, babies already can identify maternal and paternal voice in the room. I encourage moms after they deliver to speak to their babies because, again, like I said, the babies can identify the maternal voice separate from any other voice in the room. Also, if you lay baby on mama's belly, any baby that's born, within an hour to 2 hours, that baby will have climbed up to the maternal chest because it's a natural response. Mama's chest smells like estrogen strongly and also of amniotic fluid. And so baby will naturally climb up to mama's breasts. It's absolutely a beautiful phenomenon. No more is it more evident that there's cultural differences between families than in the labor room. Many different cultures, that's listed in your book, have different intricacies involved in the birth process. I encourage you guys to look through these. I wouldn't tell you to necessarily memorize one certain type of cultural difference. I do think the Asian cultural differences with birth are important to know, though, because the Asian people believe that birth is a warm process, and so they will avoid cold anything for a good month. For example, if you offer them a cold Gatorade, they'll decline, but if you offer them some warm tea, they will accept. So let's talk about the phases of postpartum adjustment. A woman by the name of Rita Rubin examined maternal adaptation to childbirth in the 60s. And what she did is she assessed a bunch of women from all different cultures and all different parts of the world and watched them after they gave birth. And she discovered that universally women go through 3 phases after they deliver their baby, and these are the taking in phase, the taking hold phase, and the letting go phase. And so let's spend some time talking about those phases. Your taking in stage, it lasts anywhere from 1 to 3 days after delivery, so this is the stage that you'll see most likely in the labor and delivery and postpartum units. And right now mom is focused on self. Mom is passive. She's dependent on you. She needs to hear instruction from you, more instruction and less teaching. She's hesitant about making decisions. Really, she's in recovery mode. She wants to talk about her birth. She wants to talk about her perceptions of her birth. And she, in her mind, tries to separate fantasy of what she thought birth was going to be like from what it actually was. And food and sleep are really her major needs. If we could keep moms forever, well, not forever, but several days postpartum, we would really do a lot more good than what we do currently, because what we do in the hospital is try to teach them while they're in their taking in phase. And again, moms are not really ready to be taught while they're taking in and focusing on themselves and their birth. The next phase is 2 to 3 days after delivery, or 2 to 3 days after the taking in phase is done. When mom is done revisiting her birth and she's ready to resume control over her life, and she's focused on her baby. She may need reassurance, but at this point she can make decisions. And this is a good stage to talk to her about the differences between postpartum blues and depression, which we'll talk about in a few slides. The last phase is letting go, and this can take weeks for mom to go through, up to 6 weeks postpartum, where she actually has to redefine her role in life. She has to see herself either as a new mother or as a mother to another child, and how this fits in with her daily activities as she resumes some normality. She gives up her fantasies of what newborns are like. Most moms have to learn the hard way, and readjusts. And it's very important that in this stage she separates herself from her infant. For a long time during the taking hold stage, it's mom-baby dyad. All they can think about is each other. But the letting go stage, mom starts to have to think about herself individually. No audio on this slide. No audio on this slide. Let's talk about the father-infant interaction as well. Infants are predisposed biologically to enjoy multiple attachments. So it is a misnomer that an infant can only be attached to the mother. They can also identify paternal voice as soon as they exit the womb. So I want to talk to you guys about engrossment. This is beautiful interaction between baby and dad right here. Engrossment is not only what the father does for the baby, holding and comforting, but also what the baby does for the father. Studies on father bonding show that fathers who are given the opportunity and are encouraged to take an active part in caring for their newborns can become just as nurturing as mamas. A father's nurturing response may be a little less automatic and a little more slower to unfold than a mom's, but they're capable of strong bonding. Studies have shown that if dad bonds with baby right after childbirth, that for the rest of that child's life, that dad will be more attached to that child than a father who has not bonded with the baby after childbirth. So it's incredibly important that these partners are in the delivery room and are involved. I've really enjoyed a lot of the students who've come through my group, and all of them have kind of said the same thing, that they've been so impressed on how dad bonds with baby after baby's born and how it's almost an automatic response. No audio. I feel like we've discussed this before in a different lecture, but I tried to go back and find it, and I don't think you guys have seen this slide, so I'll go through it in detail. It's very important that the nurse is aware of the differences between baby blues or postpartum blues, postpartum depression, and postpartum psychosis, because these are 3 separate individual psychological phenomena that happen. Let's talk about the most common, which is baby blues. I'm sure you guys have heard about it, and I've heard parents talk about it. Up to 85% of women have baby blues, and it resolves within, I want you guys to see this, 10 days. Okay? So moms are tearful, they cry, they're tired, they're slowish, and they're cranky. And that's very, very normal postpartum. I mean, think about what they just went through. So tell these mamas, provide them reassurance of how common it is, that they aren't just as joyful and happy as ever that their baby is born, that then maybe they cry, and that's okay. That's normal. But 20% of these patients develop postpartum depression within 1 year, and these women need to know that if their baby blues continue 2 weeks after delivery of their baby, that they most likely have postpartum depression. These women need therapy, okay? These women need therapy because unfortunately postpartum depression can persist and worsen into postpartum psychosis, which is the most severe form. And unfortunately, these women can suffer from delusions. Look here, guys. Unusual behavior, emotional lability. I mean, these women can truly have psychotic breaks where they threaten to hurt themselves or their child or someone else. These women can actually have inpatient hospitalization. They may be admitted to a psych ward. And fortunately, Brooke Shields drew a lot of attention to this issue when she wrote her book about how she would lay her baby in the corner of the room and sat there and thought for hours about how she didn't care if her baby lived or died, and how she knew that this was wrong, and how she eventually sought treatment. Postpartum psychosis is a real issue, a real thing, and we need to be vigilant and continue to check for this up into the woman's postpartum visit. No audio. Breastfeeding. We're going to spend a lot of time in this lecture talking about breastfeeding. I want you guys to be personally responsible for educating women and men and anyone else you come in contact with that breastfeeding is best. Unfortunately, our culture sees breasts as sexual organs and not what they are intended for, which is the feeding of a human child. Other mammals drink their mother's milk, and we are the only mammal class that provides milk from another animal to our own children. For example, cow's milk. Other animals don't do this. So it's important to know how important, again, I can't use the word important enough, I think I've said it 10 times, that breastfeeding is. It is better than formula and any other type of milk we could give a child. It's bacteriologically safe. It's fresh. It's readily available. You don't have to mix powder with water. You don't have to worry about buying sterile water. You don't have to warm it up. You don't have to worry about bottle contamination and thrush that can develop in the milk. And what most people don't realize is that breast milk changes. Composition constantly changes. So if mama delivers her baby preterm, her milk will be higher in protein and electrolytes than a mama who delivers her baby term. And a 1-month-old baby's milk will be different than a 6-month-old baby's milk, will be different than a 12-month-old baby's milk. So mom's body naturally makes milk different weekly for her baby, providing just the nutrition that her baby needs. Lactogenesis is the medical term for the production of milk. And what we need to remind moms is that milk is only made by hormones. 2, in fact. Here's your first and here's your second. Prolactin and oxytocin. Prolactin is the hormone that's responsible for forming the milk in mom's breast. And oxytocin is the hormone responsible for contracting the muscle to eject milk. But we also know that oxytocin contracts the uterus to make it smaller. So women who breastfeed have a quicker return of their uterus to normal than women who don't breastfeed. Lactogenesis is highly regulated by the brain and endocrine system. It truly is fascinating. The reason why I'm spending so much time on this these hormones and the production of milk, is because when women come to me, and they come all the time and say, I'm not making enough, my answer to them is because you're not feeding enough. And that generally draws back some unkind words, but let's talk about this. When I place the baby to my breast, I make prolactin. And the more I put the baby to my breast, the more prolactin I'll make. Thus, the more milk I make. So this is what tends to happen in women. They go home, they are all gung-ho about breastfeeding, which is great, and they get tired. They get tired because breastfeeding is harder than formula feeding, and the reason why is because breast milk sits in the gut less or shorter than formula. Formula-fed babies usually go about 4 hours in between feeds because formula is thicker. It sits in the villi longer, and babies aren't as hungry as a breastfed baby because the formula's sitting in the gut. Breastfed babies clear their breast milk faster. They have more stools, and so they're hungrier more. And so these mamas go home and they're tired. And when they get tired in the middle of the night, they tell their partner, grab a bottle of formula and just give it to them so I can sleep. Guess what? Boom, immediately the next day or the day after, they'll start making less milk. Why? Because they made less prolactin. But the reverse is also true. If I want to make more milk, I have to stimulate my breasts more. And so we teach women to power pump. We'll tell them if they have low milk supply to go home, get in front of the couch, turn on the TV, get their pump out, and pump for an hour. And what they do, turn their favorite show on, let's say Walking Dead. Let's say their favorite show is The Walking Dead, right? They'll turn it on, and every time a commercial comes on, they'll pump. The commercial goes off, all the commercials go off, the show's back on, they'll stop pumping. A commercial comes on, they pump. Commercial goes off, they stop pumping. And they do this for an hour. And so basically they'll cycle through every 10 minutes, pumping and not pumping. And they'll see an increase in their supply within the next 2 days. And tell me again, class, why? And I'm going to hear you all say, because they're making prolactin. And that would be the correct answer. This is another slide kind of demonstrating what I described on the prior. Again, here's our two big power players, our prolactin that produces and our oxytocin that releases milk. Both are made endocrine-wise from the brain, and suckling stimulates both. While the mom is pregnant, we know estrogen grows tissue, so it forms new ducts. And when that placenta is lost, placenta is primarily responsible for progesterone. And when that placenta is lost after the baby is delivered, your progesterone levels drop dramatically. When your progesterone levels go down, your prolactin levels rise. This is important when we talk about postpartum birth control, which we will in a few slides. But if I give my mom hormonal birth control, like progesterone, what's going to happen? I'm going to have decreased milk production. So we'll talk about that. If mama goes more than 3 hours after breastfeeding, her prolactin levels will drop. So if mom skips a feed, her prolactin levels will drop. Postpartum, if mom has not stimulated her breast by 3 or 4 days, her levels will drop significantly. It will become very difficult for her to produce milk. And by 2 weeks, her hormones will be back to pre-pregnancy levels like yours and mine are. It's also important for you as a nurse to know the differences in breast milk. We have 3 types. We have colostrum, we have transitional, and we have mature. Colostrum is the first milk made, and it actually begins forming mid-pregnancy. So if a mom delivers premature, she'll still have colostrum ready and available for her baby. Colostrum, as you can see, is really thick and yellow, and babies only need a teaspoon of this, 5 mLs of this, for the first couple of days, and that will sustain them enough before mom's milk comes in. Colostrum is so important to baby. It's so rich in fat-soluble vitamins, and remember your fat-soluble vitamins A, D, E, and K. And let's especially talk about vitamin K because we give this in an injection form to the baby's leg after they're born. Fresh newborn babies do not synthesize vitamin K because vitamin K is synthesized by bacteria in the gut. Babies who are just born don't have bacteria in the gut because they were born out of a sterile environment. So we in the hospital administer a vitamin K shot to the baby who has a sterile gut, so they'll have enough vitamin K until they start to colonize their gut by eating. Vitamin K, we know, is the vitamin that's most important for clotting. K for clot, even though it's spelled wrong. Clot. Okay, so breast milk, colostrum is naturally rich in this vitamin. Colostrum also promotes the establishment of lactobacillus in the gut. You guys know how important probiotics are even in our adult patients. Some of you may even take them yourselves. Well, colostrum is rich in probiotic. And even more fascinating is that colostrum is a natural laxative. And the reason why we want to encourage a natural laxative in a neonate, is because a natural laxative like colostrum promotes excretion of bilirubin. So these babies are less at risk for being jaundiced. Colostrum will eventually change into transitional milk and then mature milk by day 3 to 5. Transitional milk is more light yellow, but still not as copious as mature milk, and mature milk may even sometimes look blue tinged. I want you guys to be experts in educating anyone that you meet, whomever is curious, about the benefits of breastfeeding and why it's better. Because we know breast is best, hopefully you all do, but when people ask you why, I want you to have answers. So let's go through these. Breastfed babies have decreased risk of cancer because breast milk helps mature the immune system faster. They respond better to vaccinations. They have less risk for eczema, and also what goes hand in hand with eczema is asthma, which I'll put over here. But both are immune responses, and because we're giving them a natural milk for the rest of their life, they'll have decreased unproductive immune responses such as eczema and asthma. Breastfed babies also have a decreased risk for juvenile rheumatoid arthritis, less likely to have tonsillectomies, less likely to have ear infections. They have better eyesight, less constipation, less UTIs, less acute appendicitis, better baby kidneys, less diarrhea. Look, guys, 6 months or more of exclusive breastfeeding reduces the risk of food allergies for life. Also, all the way into adulthood, these patients have less risk of Crohn's disease and ulcerative colitis. It's phenomenal. I want you guys to know that breastfed babies are smarter than formula-fed babies by at least 5 points IQ. Why? Because it has more DHA and your other arachidonic acids than formula can ever add to it, which helps grow nerve and brain tissue. For the rest of their life, they have a lower risk of diabetes. For the rest of their life, they'll have better dental care, and they'll also be able to eat a more variety of foods in their adulthood. Less respiratory infections, less wheezing such as asthma, less pneumonia. And for the rest of their life, I love this, they'll have lower cholesterol. There are some contraindications, though, to breastfeeding. Not everyone can breastfeed. Okay, guys, this is important. Women who are HIV positive in the United States cannot breastfeed. This is different for women who live in very poor countries who don't have access to formula. At that point, it's either they breastfeed or their baby dies. So you'll see women breastfeeding in Africa who have HIV, but in the United States, women who have HIV cannot breastfeed. Women who have active tuberculosis should not breastfeed. Women who have herpes on their nipples. Women who are undergoing chemo, who are taking lithium, or women who are have had contrast, such as a CT with contrast or an MRI with contrast, should not breastfeed. And last but not least, there is a very small subset of patients, of babies, who are allergic to lactose and have galactosemia, who should not receive maternal milk. All right, when is a baby hungry, right? Parents ask this all the time. I don't know when my baby's hungry or when they're not hungry. And there's early cues, mid cues, and late cues. And when there's late cues, this really makes it a miserable experience for both mom and baby. Because if we're starting feeding when the baby's screaming their head off, this is going to be miserable for both mom and baby. Okay? So mom needs to start feeding when the baby's here. And I want you to see how there's this hand by this baby's face, and the baby starts chewing on it. Right here. Okay? These babies are hungry, and this is when we should feed them. If we wait again till they're crying, it's going to be a miserable experience. There are several different positions mom can assume when breastfeeding, and I'll show you guys a picture on the next slide. We have cradle, we have cross cradle, we have sideline cradle, or even inverted side lying. And what's missing from this slide deck is football hold. Football is another breastfeeding position where mama is here. She holds the baby. Here's her breast, and here's baby's head, and she holds the baby underneath her arm as if she's running for a touchdown, if that makes sense. And I know that's a very crude drawing, but it's also in your skills book, scale 16.19, I believe, if you want to look at a picture of it. All right. These are any position that mom feels comfortable in, she should assume when she breastfeeds. Ineffective breastfeeding is an issue, and it's not always necessarily mom's problem. It could be baby's problem too, like their tongue tie. So I want you guys to see here how deep the nipple goes into the baby's mouth. And I want you to take a minute and run your tongue across the roof of your mouth and feel where the hard palate meets the soft palate. And we want mom's nipple to go past the hard palate into the soft palate. So think about how deep that has to go. Because the way milk exits the breast is through the thrusting of the baby's jaw. It really has nothing to do with the baby's lips itself. But if the nipple isn't back far enough that the jaw can't thrust and gulp and thrust and gulp, you're not going to get any milk expressed into baby's mouth. If mom's breasts are engorged and they're hard, the tissue's not soft enough to really wrap around baby's face. If mom's nipples are inverted, the nipple can't get deep in the mouth. Or if the baby has latched incorrectly, the nipple can't get deep in the mouth. Let's talk about tongue tie for a second. If you look underneath your tongue in the mirror, here's your tongue and here's your teeth. Here's your jaw. I know, again, a very crude drawing. You'll see in the mirror you have a piece of skin tissue called your frenulum right here. Here's your top jaw and your top teeth and your nose. This is your frenulum. Some babies are tongue-tied, in which they have a very tight frenulum that's all the way up here. So their tongue is literally tethered to the bottom plate of their mouth. And we actually have to cut that with scissors. So providers have to come in and cut this out. So the baby can actually pull with their tongue the nipple back into their mouth. Moms need a lot of help breastfeeding. Just because it's natural doesn't mean it's easy. It's difficult and challenging because baby's never done it, and if mom's never done it, you have two novices that don't know what to do. So you need to teach them 3 things. Okay, I'm going to teach you. You guys are going to be breastfeeding pros. The first rule is nipple to nose. When you put the nipple and touch the baby's nose with it, the baby will naturally root and open their mouth wide. The mouth has to be really open wide because you want all of the areola in the baby's mouth. You see here how you see no areola in this picture? All of the areola is in baby's mouth. That's the way you want it to be. You want that chin tucked back. All right, second rule is that you want baby's belly to be next to mama's belly. Bellies to be touching. You do not turn your head to the side over your shoulder and drink out of a glass that way. You drink with your head midline. And for some reason, I don't know why, we expect babies to drink with their head to the side while they're laying on their back and we turn their head to breastfeed. And that is not how anyone drinks naturally. So baby's belly should be laying on mom's belly. That's the way it should be. That's your second rule. All right. And your third rule is you bring baby to breast. You never bring breast to baby. And the reason why is if mom's leaning over babe is most likely laying on his or her back, but also it will hurt mom's back. And as soon as mom becomes uncomfortable, baby will become uncomfortable. I know you guys have experienced when someone is angry and they walk into a room that baby begins to cry. Well, that's because babies can feel tension in the room. So if mom's uncomfortable, baby's going to be uncomfortable, and breastfeeding is going to be miserable. The ear should be in line with the shoulder and the hip, and the nose should be level with the nipple. The head is in a sniffing position, and the best thing for mama to have is really a boppy. I love to tuck mamas with a boppy and put the baby on top. Milk will let down about the third day, and mom will actually feel tingling in her breast. And when the baby is done breastfeeding, mom will feel her breast be lighter. You guys should see the jaw thrust forward and the swelling occur in a 2-to-1 or 1-to-1 ratio, meaning 2 jaw thrusts and 1 swallow, 2 jaw thrusts and 1 swallow. You can hear it. If baby is jaw thrusting with only 1 swallow, a ratio of 5-to-1, that baby is really not moving milk. So for example, you should see swallow, swallow, but if you see swallow, that baby's not getting a lot of milk, okay? Also, if mom is having an effective breastfeeding, she'll have uterine cramping. Why? Because she's releasing oxytocin. She may have increased lochia, and she may experience breast milk leaking from the other breast, okay? Feedings that last longer than 30 minutes are not satisfactory, and why? It's because babies are really burning more calories than they are spending and eating. It's also important when mamas ask you, well, how do I know my baby's getting enough, other than all the things we just talked about, is to tell her that babies will absolutely lose weight their first week of life. They'll lose 10% of their body weight, but regardless of how mom's feeding. But after the first week, they should gain. Babies who are gaining weight are getting enough calorie. This is a picture of great attachment and a picture of poor attachment. So this mom has very large areola, so the baby can't get it all in its mouth. But see here how the baby is just kind of on the nipple. This mama, if the baby continues to nurse this way, in about 2 or 3 days is going to be raw and bleeding, because all he is doing is just really just kind of chewing on her nipple. Babies will also be milk drunk if they've gotten enough milk, and I like to watch their hands. If the baby detaches himself from the breast and his hands are relaxed, you know he's full. But if he detaches himself and his hands are still tight, most of the time he still needs to be topped off. Babies who breastfeed will feed about every 2 to 3 hours, and babies who are formula fed feed about every 3 to 4. Here's a great picture of a tongue tie. This is obviously in an older child with a bunch of teeth. But you can see how this tongue actually becomes heart-shaped because it's so tight. This frenulum is so tight. If mama has to pump, let's say mama has to return to work, or baby's unfortunately sick and in the NICU for some reason, we want mama's milk. Milk is best. And so I like to teach them the rule of 6. Mom can pump and leave her milk out at room temperature for 6 hours. Mom can pump and leave it in the fridge fresh for 6 days. Or mom can pump and put it in the freezer for 6 months. That's kind of my rule of 6 I teach moms. They need to, if they're pumping, they need to label their milk with date and time. And when they give it to their baby, they want to use the oldest milk first. This makes sense because if my baby's premature and I use premature milk that they pumped prior, then the baby's going to get higher protein. But if I use the milk she pumped at 6 months first, then the baby's going to get the wrong nutrients, if that makes sense. Okay? So if mom has a deep freezer full of milk and she asks you where to begin, you start with the oldest first. When you thaw milk, you put it in a bowl of warm water. I'd never, ever, ever microwave milk. It creates hot spots in the milk that you don't realize. And the baby can take the bottle and then all of a sudden start screaming, and you know that you've burned the baby's mouth. When you thaw milk, it does decrease the anti-infective properties. So all those good antibodies that are in the milk kind of go away when you thaw, but it's still better than formula. And you never refreeze milk once it's thawed. Same with meat. Never refreeze meat once it's thawed, because it just increases the risk for bacterial overgrowth. A few breastfeeding extra tips. If mom's nipples are really dry and cracked, you provide lanolin cream. This is one brand called Lancino. I don't necessarily recommend this brand, but the cream is called lanolin. Lanolin. The great thing about lanolin is that if it's oil-based cream, and if mom's nipples are dry and cracked, she can place this on her nipples to heal them. But the great thing is that she can continue to breastfeed while she has lanolin on her skin, because it's safe for baby to consume. This is a picture that shows to avoid hormone-based contraception, and we talked all about that the last time we met. Why? What did I tell you guys? When the placenta is moved, progesterone decreases. And when progesterone decreases, prolactin increases. And prolactin is what makes milk. Well, if I give my mama progesterone only, or a combo pill, or I give her an IUD with progesterone in it, or I give her the depot shot, I am essentially decreasing prolactin for them almost immediately. So I like to teach moms who are really adamant about breastfeeding, and maybe who are having some milk supply issues, to try to use barrier methods of contraception until they stop breastfeeding, just so they can produce the most milk. So nursing care for a lactating mother, we want a supportive bra, so no underwires. Underwires will constrict certain lobules on their breast, and they may experience engorgement. We want to teach them about the correct position. We want to make sure that the baby's latching on well. When warmth is placed on her breast, she'll make more milk. And if she is struggling with sore breasts, sorry guys, it is Thanksgiving and my kids bombarded. So I believe I was in the middle of saying that warm dilates, cold constricts. So we want to encourage mama to apply warm compresses to her breast, or take warm showers if she's trying to increase her supply. If mom exposes her nipples to air, especially if they're sore, and especially if she puts colostrum or breast milk on her nipples, it acts as a natural skin barrier and will help her heal. Nutritional needs. This is the best part of breastfeeding. These mamas need an extra 500 calories a day to make milk. So these moms can intake 2,500 to 2,700 calories per day postpartum if they're breastfeeding. And so really they get to eat what they want. Compared to women who formula feed, those women have to decrease their caloric intake by about 300 a day. Dads sometimes feel useless when moms breastfeed, because mom is providing the milk, and dad kind of doesn't have as much hands-on care with the babe. So I always tell dads that when mom sits down to breastfeed, you bring her a glass of water. And so you are making milk. And the reason why is when you give her water, she's hydrated enough to make milk. So you're helping the baby just as much as she is. Moms have to have 8 to 10 ounces of glasses a day. So that, again, that to tell dad that means a lot. When she sits down for baby to eat, you feed her so she can make milk and bring her water. Just the opposite is true for non-lactating women. They want to avoid stimulation. They also want to wear a supportive bra. If they go braless, they'll really engorge heavy. They want to use ice packs because cold will cause vasoconstriction, which will decrease the availability of hormone through the bloodstream to the breast to make milk. Cabbage leaves are scientifically researched and do help decrease milk production. The phytochemicals they have in their leaves, providing that mustard smell when cooked, when they are applied to the breast, have anti-inflammatory properties. So they will help women who are engorged or women who are not choosing to breastfeed. Mamas can take a mild analgesic for discomfort. And these, again, need less than 300 kcals than what they've been taking while they were pregnant. So they can't eat what they want, which is hard for them. Both women need iron supplements for at least 2 to 3 months after they are done breastfeeding. Discharge instructions. We talked about this briefly in our other lecture, but it's absolutely important that you go over discharge instructions when both mom and partner are in the room. Why? Because they need to abstain from sex until that lochia has stopped. We know that while the lochia is continuing, the cervix is open, and while the cervix is open, there's risk for infection. So until patient is all healed and flow has stopped, they should abstain from sex. Mama should also have sex after she's done breastfeeding. Excuse me, if she needs to breastfeed baby and then have sex, not have sex and then breastfeed baby, because she'll become engorged if she does the reverse. Discharge is a great time to start talking about contraception. Why? Because just 27 days after mom delivers, she could get pregnant potentially again. Baby has to have, there's always a discharge checklist when baby is discharged that you have to go over with mom, and these are some of the items on the discharge checklist, but one of them is a pediatrician follow-up within 3 to 5 days. Also, the postpartum nurse who's discharging mom and baby physically has to walk the baby down and watch mom place the baby in a car seat appropriately and place the car seat in the car appropriately. So the car seat has to be placed in the back seat, rear facing, with the straps snug over the baby, only 1 to 2 finger breaths in between the strap and babe, and the trunk support should be clipped in between the nipples, and the pelvic support should be placed in between the legs. If moms are breastfeeding, they need to know their community resources, whether it be that they can come back to the hospital anytime and speak to a lactation consultant, or whether they need La Leche League. La Leche is a nationally known and internationally known organization. It stands for the Milk League, and these women sit around and they're either lactation consultants or women who breastfed or previously breastfed and support each other through what is natural but not easy. We've talked about vaccines. We've talked about mom needing to be up to date on her Tdap and her MMR and her flu. And we've talked about baby being up to date on their Hep B when they're discharged. No audio. Variation for C-section. Whether cesarean section is elective, although that's not done very often anymore, or it's urgent or emergent, these patients not only are postpartum patients, but they're also surgical patients. So you have to consider more things with these patients than you would others. Women who have had anesthesia need to turn, cough, and deep breathe. Why? Anytime you undergo anesthesia, you are at risk for not completely opening up your air sacs. When you don't completely expand your alveoli and take deep breaths, because you're underneath the influence of anesthesia, you can get pneumonia. These women also have surgical wounds that you have to evaluate. These women also are at increased risk, more so than a vaginal postpartum woman, for DVT. So they need leg exercises every 2 hours or SCDs until they can get up, and they can usually get up about the second postpartum day. These women have Foley's longer, because of the effects of the epidural or spinal or unfortunately even general anesthesia. So they're increased risk for UTIs. They have more pain because they're surgical patients, so they'll need higher pain control. They will bleed, they will have lochia, but it will be slightly less than a vaginal birth. And don't forget the bowel and its decreased return to function, which we talked about in the very first slide of this lecture. Postpartum hemorrhage is your biggest complication, your biggest and worst complication of the postpartum period. We know that postpartum hemorrhage is unfortunately the leading cause of both maternal morbidity or death, complications, long-term complications, and mortality or deaths, not only in the U.S. but nationwide. I think the last study I read in Afghanistan on women who deliver in Afghanistan was that 1 out of every 8 women who become pregnant and deliver in Afghanistan and Iraq die, which is just I can't even imagine. If 1 out of every 8 women who got pregnant died, we would have millions upon millions of women dead. And why? It's because of postpartum hemorrhage most of the time. Any spontaneous vaginal deliveries or SVDs lose 500 mLs or less of blood normally. And cesarean births lose 1,000 mLs or less of blood normally. So if you have an estimated blood loss of higher than those two values in those two circumstances, that's the definition of postpartum hemorrhage. And the cause of postpartum hemorrhage is always, 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 always uterine atony. The prefix A is Greek for without or none. So when I say anuria, we have no urine. And when I say atony, I have no tone. And we know in all the postpartum fundal assessments that we've done that the uterus is supposed to feel tight after it's given birth. Now we have risk factors here for women who have atony or no tone to their uterus. Boggy, boggy, boggy. And you guys need to know these. Women who have prolonged labors, long labors, they labored for 26 hours and they pushed for 6 hours. I mean, not like that happens very often, but sometimes it does. And their muscles are actually lax, secondary to a long labor. Anesthesia causes muscles to relax and can cause uterine atony. A difficult birth can cause uterine atony due to excessive manipulation. Grand multips. More my uterus expands and contracts and expands and contracts and birth and birth and birth and birth and expands and contracts over and over and over again. The more it happens, the less I'm able to contract well. So they have diminished tone from repeat stretching. We know, we've already talked about this, that a full bladder will push the uterus to the side. Retained placenta. We haven't talked about this before. But that is why you guys, if you've seen a vaginal birth, a cesarean birth, when the placenta is emerged, the provider and the nurse look over it so well because they're making sure that it's intact and that there's no piece inside left in mom. Because we have retained portions of the placenta, if a piece of the placenta has torn and retained to the wall, not only will the placenta continue to get blood, so mom will continue to bleed onto it and into it. The uterus won't contract because there's pieces of tissue in there and it can't fully touch down, if that will, crouch down. Infection causes inflammation, causes decreased tone. And if we have overdistension, last but not least, overdistension of the uterus, for example, mom has had twins, triplets, quads, quints, you name it. Or if mom has had polyhydramnios, too much amniotic fluid, or if the baby is LGA or large for gestational age or macrosomic, if mama had diabetes or those types of things, a 10, 11, 12 pound baby, you'll have a slower return of normal function of the uterus and you'll have overdistension. Let's talk more about retained placentas. There's two types. We have non-adherent placentas and adherent placentas, and I'll show you a picture of adherent on the next slide, which is better to see. But let's say that the mom has delivered a baby, and we know that placenta is supposed to come out intact within 15 minutes. Well, if it doesn't, The provider can attempt to insert their hand and remove the portion of the placenta with their fingertips, which can be incredibly painful. Or the mom will have to actually go back to the OR immediately and have a D&C, dilatation and curettage, and actually have that placenta removed. Again, it's life or death for her, so there is no choice. It needs to come out. Let's talk about adherent placenta, which are shown better here. This is my normal uterine wall, and we have the top of the wall, which is the endometrium, the top layer of the uterus. And this is the portion, the layer that grows in response to estrogen, and when it doesn't get pregnant, it sheds every month. This is what we shed, and women shed in their period, in their menstrual cycle. Well, the placenta can actually adhere through the endometrium into the muscle layer, or myometrium. It's supposed to be myometrium. It can extend, the placenta can extend into and attach to the outside of the myometrium, and we call that placenta accreta. The placenta can extend deeper into the layers of the myometria. We call that placenta increta, and the placenta can attach and extend all the way through, unfortunately, through the uterus, and we call that placenta percreta, which is much worse than the other two. I've been to many of these deliveries. This is diagnosed by ultrasound. If mom hasn't had prenatal care, though, that's an issue. Unfortunately, what happens is because mom is at such a risk for bleeding, and baby is such a risk for bleeding, we put these moms underneath general anesthesia, and we perform cesarean sections guided by ultrasound. And we attempt to remove the placenta from the uterus, but if we cannot, most of the time, these women have to have a hysterectomy and just have the entire uterus removed. Postpartum hemorrhage can be diagnosed as early versus late. You guys can see that definition here. Pretty self-explanatory. Interventions for postpartum hemorrhage. If we don't intervene in a postpartum hemorrhage, mom will die. This is why moms are dying in third world countries after the delivery of their baby. And you guys know the first thing we do is massage the fundus. When you massage the fundus, it causes the uterus to contract. We also make sure that we don't have any competing bladder distension. If mom continues to have postpartum hemorrhage, we obtain IV access, at least 18 gauge or lower. We're going to talk about meds in the next slides. You need to notify your OB immediately. We start to monitor for shock. We start to replace blood and fluid as ordered fast. And whenever we have a situation like this, and the different, I work in a very scary world where things happen quick, fast, and oftentimes very poorly. And when these types of situations happen, the OB or midwife is focused on mom. The primary nurse is focused on mom. The neonatal team is focused on baby. And who is focused on telling the family what's going on? Nobody. Nobody. And so mom has literally no idea what's going on, and she just hears a bunch of people talking and things going on, and dad doesn't know what's going on, and people rip stuff out of the wall and run mama to the OR, and things go crazy. So we have now decided that when a situation goes wrong in L&D or neonatal world, that someone comes in, whether it be another experienced nurse who's nearby, or a charge nurse, or even an experienced respiratory therapist, someone who knows what's going to happen and has seen this before. Their only responsibility is to stand next to mom if she's coherent, or dad, and talk them through what they're seeing. Okay, now someone's putting an IV in because we need to give blood to you. Okay, we're gonna put in another IV because we're gonna give meds in that IV. Okay, now I want you to know that this is the neonatal team, and they're here to look at your baby. Okay, now they're going to take the baby over to the radiant warmer. All right, mom, now I want you to know that the anesthesiologist is coming up right now because we're probably going to have to take you to the OR. Someone has to stand there and walk her through it. So let's talk about these meds. There's 4. You guys are familiar with oxytocin, which is endogenously made. Synthetic oxytocin is called pitocin or pit. It contracts the uterus. Methergen also contracts the uterus, but I want you guys to see here. Your biggest side effect is hypertension. So if mom already has hypertension, heart disease, or pre-E, we don't give it. Other 2 meds is miso. Miso will contract the uterus, and likely these can be given oral or rectal. And we can give carbaprost. Okay? Takeaway message here. If I have uterine atony due to a retained placenta, I can give these medications all day long, and I will not stop bleeding, if that makes sense. Why? Because I still have placenta in the uterus. The same thing goes for lacerations. If mom is bleeding because she has a severe cervical laceration, first, second, third, fourth degree, I could give her these meds all day long and her uterus will be nice and tight, but that's not the cause of her problem. So I'm going to show you guys, oh, no audio. You can look through this, pause it and read through it. Pause it and read through it, no audio. This is a basic slide that shows you guys what shock looks like, and you've learned about this before. But shock can be mild, moderate, or severe, regardless of the type. Septic shock, anaphylactic shock, doesn't matter. Your first insidious signs is an elevation. Why? You initiate fight or flight response. So your blood pressure will go up a little bit, your heart rate will go up a little bit, and mom will become cool, pale, and anxious. And then eventually everything will progress where fight or flight doesn't work well anymore to save. You'll have decreased urine output, decreased blood pressure, decreased heart rate, blunted level of consciousness. Okay, so this is a slide that will really help you guys walk through the management of postpartum hemorrhage. Now this is something that I found online. So this is a 1 unit's algorithm for managing postpartum hemorrhage. So this may not be perfectly matched in other units, but I want you guys to see how well written out this is, and this is a way that you can learn what to do for postpartum hemorrhage. So mom has had 3rd stage of labor. Her baby is delivered. What's the first thing we do in most hospitals? Baby comes out, we give PIT. Give PIT right away. We pull on that cord, the umbilical cord, and await the delivery of the placenta. The placenta is delivered within 15 minutes. Everything goes well, nicely. We inspect the placenta, and the placenta is all intact. Then what do? We massage that fundus within 15 minutes of the delivery of the baby. But for some reason, mom is bleeding. And mom's bleeding normal than the normal estimated blood loss of a vaginal delivery, which is less than 500. So what is this mom? She's a postpartum hemorrhage. So what do? The first thing is we provide a bimanual uterine massage, and that I showed you that picture a couple of slides ago, where the provider is pushing on the top of the abdomen, of the top of the fundus, and believe it or not, is fisting the fundus, or excuse me, the uterus from inside the vagina. Pretty painful. We give her a bolus of PIT, and we give her a bolus of fluid. We start to look around the genital tract. Does she have a laceration? Does she have a hematoma? We'll talk about hematoma in a couple of slides. Is there something going on here that I didn't see? We double check that placenta again. Is the placenta completely intact like we thought it was, or does mom have retained placenta? And then we get some blood work. Is mom not clotting well? Is this DIC? Does mom have a clotting problem that we didn't know about? We get a type-in cross and a coag so we can eventually give her blood if she needs it. This is your etiology of postpartum hemorrhage. Tone issues, we give carbaprost, miso, methergen. Trauma issues, like a laceration, we sew her, we drain the hematoma. If it's greater than 3 cms, we'll get to that in a couple slides. Or if mom has prolapsed her uterus, we return it. If the placenta is retained, if it's a tissue problem, we cut out the placenta issue in the OR. And if it's a clotting problem, we give her clotting factors, FFP, we'll give her recombinant factor 7A, and we'll give her platelets. If she starts to go into shock, we will place 2 large IV catheters, provide oxygen, continue to approach her, and have a team-based approach. Lots of people in that room, lots of people. The bottom portion of this algorithm is on the next slide. If mom has an extreme blood loss of greater than 1,000, we initiate vasopressors. She's an ICU patient. We pack her uterus, and if we cannot control her bleeding, we will perform an emergency hysterectomy, which could be devastating to her. Here's a great picture of the cervix. So here we have a speculum inserted inside the vagina. This is your vaginal wall, and this is your cervix right here. It's supposed to look nice and round like a donut, but you guys can see this big tear. Lacerations of the genital tract happen more often with an operative birth, a precipitous birth, or a fast labor. Any abnormalities of the bony pelvis or soft tissue. If the baby's too big, if the baby's presented wrong, if the mom has had a previous STD and she has scarring of that area. We know we've talked about lacerations before, and they can be classified by 1st, 2nd, 3rd, or 4th degree lacerations, meaning it's lacerated into the skin, into the muscle, into the anal sphincter, or into the anterior rectal wall. And you guys need to be aware of how to check for a cervical laceration. If you have a woman who has a tight, firm uterus, but she's still trickling continuously blood and her bladder's empty, there's no other reason for it, that's when you start to suspect a laceration. And it is treated by suture. The provider will suture the laceration. Great picture of a hematoma. I told you we talk about them. On the previous algorithm, if the hematoma is greater than 3 centimeters, they do need to be drained. A hematoma, all it is a collection of blood. It is usually painful. You'll start to suspect one if mama says, I feel a lot of pressure in my vaginal or rectal area, or I feel pain and I didn't feel it earlier after she's delivered. You need to investigate, okay? These, unfortunately, hematomas can get so big that mom can go into shock from them. And again, they are surgically evacuated. DIC is a review. You guys learned about DIC in MedSurg too. What's most important to learn about disseminated intravascular coagulation is that it's not a disease, but a symptom of sepsis, a symptom of clotting issues, a symptom of shock. It can be a symptom of different disease processes, but basically, mom clots so much that she has no clots left. So I'll let you guys review that on your own time. Postpartum infections. Endometritis is something that we should be careful of and look for in our postpartum patients up to 6 weeks. And endometritis is most common in your women who have had a cesarean section. Why? Because we've literally cut into the uterus. If we've cut into the uterus, there's a great chance, even though as sterile as we can be, that we've introduced some bacteria into the uterine wall. Your signs and symptoms is a woman who has a fever within the first 10 days postpartum, excluding the first 24 hours, because we know fever is common during the first 24 hours. On 2 occasions, that's greater than 100.4. The first thing we think of is endometritis. Women who are also at risk for endometritis are women who don't heal well, like women with poor health status, who smoke, who have poor nutrition, those types of things. We need to teach mamas who go home that their drainage should never again smell foul. You would be concerned at that time that if her lochia smells foul, that you have endometritis. Here's your treatment for endometritis. I'll let you guys read over that. No audio. No audio. Mastitis. Mastitis is your most common breastfeeding complication. And believe it or not, 1 out of every 10 women have mastitis when breastfeeding in the United States. I want you guys to know, and it's bolded here, that the reason women get mastitis is from milk stasis. Now, there's lots of different things that can cause milk stasis, or the sitting or pooling of milk. But the biggest reason for mastitis development or painful inflammation of breast tissue is milk stasis. And it's diagnosed clinically. If you saw a woman with a red, tender, hard, painful breast like this, right away, boom, there's your diagnosis. We don't rarely ever culture the breast milk. It's just pretty clear to us. What we need to look for is, why is the milk pooling? Let's see, is the baby having an improper latch? Is mom engorged? Is mom potentially sideline breastfeeding or wearing an underwire bra and her milk ducts aren't emptying? Is she too tired to fully breastfeed? Or is the baby latching poorly, and so she has nipple trauma? And if she has nipple trauma, staph or candida can climb up through that crack in the nipple and into the tissue surrounding the breast. But the take-home message for mastitis, and this is a misconception, is that when a woman has mastitis, she can't feed her baby because she'll make her baby sick. And that is absolutely false. In fact, the opposite is true. The inflammation and/or infection is in the breast tissue itself, not in the milk gland. So we want to not only clear the milk out, because the problem is a milk stasis issue. So we want her to feed more, pump more, put warm compresses on her breast. But we also want the baby to get milk, because the milk has antibodies in it that will potentially benefit baby down the road. So moms need to pump more and feed more when they have mastitis, and not less. There are some very rare complications of mastitis. So if you have mastitis that's not cleared by emptying the engorged breast and/or placing the mama on an antibiotic, then you need to be concerned about a breast abscess. So staph can grow in, sit there, and kind of encapsulate itself in the breast, and so mom may need to have her breast lanced and drained, but that is, again, very rare. Most of the time, women can feel mastitis coming on. It becomes extremely painful for them. They'll have symptoms of flu, malaise, fever, a hard and painful breast, and we get them to pump and put hot compresses on it and empty it, and it hurts like the dickens, but once it's cleared, it's done. Clots. We've talked about clots, I think, 1,000 times in this lecture. 1,000. Clots can be superficial, clots can be deep, or unfortunately a clot can break off, become an embolus, and travel to the lungs, or potentially even to the brain. We talked about already your risk factors for clot formation in previous slides in the beginning. I want you guys to see how insidious this looks. The longer you become a nurse and are a nurse, your assessment skills will increase. And so someone who may not know necessarily what they were looking for might not see the difference. But this right leg is inflamed and reddened right in these areas. So this mama does have a clot. And her leg is sore. So in this mama, you would definitely not want to elicit a Holman sign in this mama. Okay, from my family to yours, happy Thanksgiving. I'm glad we were able to put this online for you. I wish you guys the best. You're almost done with maternal infant, and please reach out to me if you have any questions, or Dr. Rivak Lutz or Professor Burial on Monday or Tuesday next week. Good luck to you guys.